Okay, chapter 14 deals with the infectious diseases, and epidemiology. Uh, One of the first things to understand as we start this chapter is to understand symbiotic organisms. These are organisms that are living inside of us. Symbiosis is basically any two organisms that are living together. There's different types of symbiotic relationships. We certainly have symbiotic relationships within us. Of those four different types, mutualism is when it benefits both organisms. So we have bacteria that are in our large intestines. The nutrients flowing through the intestines is helping for survival of those bacteria, so that's a benefit to them. And actually, these bacteria do benefit us from this standpoint. Some of them make things like vitamin K, so it's benefit to both members. Commensalism is when there is a benefit to one organism and the second organism, it doesn't really benefit, but it doesn't harm it. It can take it or it can leave it. Commensalism is where, once again, you have one organism that can take it or leave it. It's not hurt, it's not benefited. The second organism, however, is harmed in that symbiotic relationship. And then the fourth type is parasitism. This is where one organism is benefited at the expense of the other one. So one is helped and the other one is hurt in the relationship. And this slide is just showing an example of termites. There are actually bacteria that do grow in a symbiotic relationship with the termites. That it grows in their stomach and intestines that helps them to break down the wood and the fiber that they ingest. We do have normal microbiota, just normal microorganisms that do live on our body surfaces. Um, it is classified as a symbiotic relationship because they're both being helped. Um, this is on our body and also in our body. Sometimes these normal microbiota are referred to as your normal flora or your indigenous microbiota. These can be bacteria, some fungi. There's two different types. There's the resident and there's the transient ones. This picture just shows an example of the pink coloration are bacteria that are found present growing in us. The resident microbiota, these are just part of the microorganisms that are growing on you and in you throughout your entire life. So most of the time, these are going to be organisms that it's a benefit to the organism, it's a benefit to us. These next couple of slides just give some examples of different areas of the body, different systems, and some examples of some of the bacteria and a few fungi that do naturally exist as part of this resident microbiota, and it's meaning they're there all the time, shortly after birth and for the rest of your life. And like I said, it's broken down by systems. So like your upper respiratory, you naturally have some staphylococcus, some streptococcus. These are not causing disease. They exist there naturally. It goes through the digestive tract, just to give you an idea, the reproductive and urinary systems, and also on like your eyes, on your skin. Transient microbiota, these are ones that are, as the name implies, they're only there for a short time. They're going to come and go. They're not staying forever. Why don't they last for longer periods and possibly throughout your life? There are different reasons. Maybe there's competition from other microorganisms. There are only so many resources. Whoever gets there first is the one that's there. Sometimes it's your body's immune cells are able to detect that, oh, this is something foreign, this really should not be here, so we're going to get rid of it. Sometimes it has to do with both physical and or chemical changes in your body that no longer is welcoming for that particular species to be there. So during fetal development, during the pregnancy, the fetus in the womb is pretty much hopefully in a sterile environment. That's the way it naturally should be. So how do we pick up these normal resident microbiotas? Organisms that would be there. You start to obtain some of them just during the birthing process. As the baby is born, passing through the birth canal, we'll pick up some organisms. And usually just by life, by eating, by being exposed to environment, exposed to people, Most of the resident organisms are going to be established within the first few months of the life of the baby. Now, sometimes these normal resident organisms can become pathogenic, and that's what we would refer to as opportunistic pathogens. Certain changes have occurred that now will make them pathogenic, whereas before they were just normal resident organisms there. How do they switch from being normal, not causing a problem, to suddenly now potentially causing disease? Number one, location. Your normal resident microorganisms are used to being in a certain location. Maybe they're found only in your respiratory tract. Maybe they're found only in your digestive tract. If they move to a different location, then suddenly it can become pathogenic. Maybe your immune system is being suppressed. You're going through treatment. You're sick with something else. Your immune system's busy fighting another infection, and that allows for organisms to kind of get out of balance. There's normally a certain balance that keeps everything kind of like a checks and balance things. It keeps everything in check, like a teeter-totter. You want to keep it even. And if it gets a little bit too heavy on one side or another, then that can upset the balance. Women sometimes see this, say if they have a urinary tract infection and they start taking antibiotics, that may kill the bacteria. But now that the bacteria have been killed, the fungi, the yeast, that are normally there in small numbers, because you've wiped out the bacteria, they can now grow to much higher numbers and cause a yeast infection. Stress causes a lot of issues in many different ways. Stressful conditions can also upset this balance and allow opportunistic pathogens to suddenly now start causing diseases. Most pathogens can't survive very long outside of a host, and so they have to be somewhere. So where are they? They're in what we call the reservoir. This is where the numbers, some of them are always going to be, it's kind of like maintaining a stock culture, if you will. But this is what happens in nature. There's 3 different types of reservoirs. There's animal, humans, and non-living. Animal reservoirs are known as zoonosis. This is going to be diseases that naturally will spread from animals to humans. There are several diseases that do spread this way. We have certainly seen recently how the coronavirus was initially in an animal host. I've been asked several questions about the coronavirus recently. We do know that this virus was in an animal initially and then spread to humans. They know where the jump, if you will, occurred. That was in China. Do they know exactly which animal it is? At this point, from what I've been reading, they're not conclusive evidence has not been found to confirm which animal it was. They know it was at a live animal market in China where the first human cases appeared, were associated with that market. But they've been focusing on trying to get this disease under control. Later, at some point, they will be looking at to determine what animal, specific animal it was that this originated in. Is it uncommon for a disease to spread, be it virus, bacteria, from an animal to humans? No, that is not that unusual. How does it spread? Well, you may have direct contact with the animal. You may have contact with its waste. Maybe you're eating an animal meat that wasn't properly cooked. Maybe it's a case of where you have insects that fed on the animal and then it likes to eat you or bite you. Humans usually, in this situation, it's going to be kind of a dead-end host. And these are very difficult to eradicate, partly because the particular pathogen is surviving in another animal host. There have been cases where the influenza virus, often the alternate host is birds. One semester I was talking with students, and and discussing this, and several years ago there's one where it was in chickens. Another year there's a certain strain that was in ducks, and I had a student who just said, well, why don't we kill all the ducks? That is not a feasible means of controlling the disease. You cannot ethically, number one, go out and completely eradicate an entire species. That is not an acceptable practice to do. Look for other means of trying to control, but it is difficult to eradicate disease. This shows on the table several common diseases that are passed from animals to humans. And as you can see, helminthic, those are worms. You've also got protozoans, fungal, bacterial, and viral. In terms of a reservoir in humans, this is when you have a human carrier, which is simply a person who is asymptomatic. Excuse me. That means the person is infected. They are usually contagious. They can pass it on to other individuals, but they themselves are not showing any symptoms. So it's not like they are trying to be malicious and mean and passing on and infecting other people. They don't know that they're even infected because they're not showing any symptoms. Now, over time, they may show symptoms later and get sick. Some of them may never get sick. This is part of an issue that you're seeing right now. And this plays into the whole role of what they are trying to do in slowing the spread of the coronavirus and why we are doing the social distancing, etc., is to try to keep people from infecting other people. This particular virus, the coronavirus, has an incubation period of 14 days, which means you could be exposed. You could contract the virus, so you could have it. You could be infectious or contagious, meaning that you could be passing that virus on to people around you, say if you were sneezing, etc. You could pass it on to them. You would not be showing any symptoms, maybe for 14 days before you even knew, oh, I'm not feeling so good. But for those 2 weeks, you've been able to pass it on to others. That is what they are trying to do right now with telling people, if you don't have to go out, don't go out. Because you may say, well, I'm not sick. I don't have the disease. You might be a carrier. You may never show symptoms. But if you pass it, say, to someone who is elderly, they're going to be higher risk. You pass it on to someone that has a pre-existing medical condition, they're going to have a higher risk than contracting, showing symptoms, and having more severe symptoms due to that particular disease. Non-living reservoirs, this is when we say soil, water, or food can be contaminated. And then if say the water is not properly treated, the food's not properly cooked, then it can pass on to humans. Once again, in microbiology, we have a lot of vocabulary, and we do distinguish between different terms such as contamination and infection. Contamination is just when you have the microorganism in your body. It's either in it or it's on it. Is it causing a problem? Maybe yes, maybe no. An infection is when the organism has become established in the body. Once again, you might quite not know yet that it's there. It's basically playing hide and seek with your immune system. Your immune system, which is there to help protect you against foreign substances, tries to combat any microorganisms when they are able to infect you. During an infection, the microorganism is trying to elude or evade the cells associated with your immune system, which we will talk about later. So how do the microorganisms, which are pathogenic, how do they get in to the body? It's what we call the portals of entry. It's 3 main ways: through the skin, mucous membranes, and placenta. Through the skin, as you can see, anytime you have a break in the skin, that's going to allow an opportunity, if the pathogen is there, to be able to enter into the body. Notice just once again with current events, how many routes of entry there are on the head, through the ear, through the eye, through the nose, through the mouth. This is part of the reason why right now they are saying, please, I know it's very tough, but try not to touch your face. You don't realize how often you touch your face till they tell you not to. Most of you, if not all of you, have had AMP, at least AMP1. And if you remember from AMP1 with the integumentary system, with the skin, the outer layer of the epidermis is actually dead skin cells. That acts as a very good barrier to prevent microorganisms from entering. However, if you have a cut, if you have an opening where somehow the integrity of that layer of skin has been compromised, that allows for an opening now for the pathogen to be able to enter. Some pathogens actually are able to produce enzymes which start to digest or break away some of those outer layers and allow the microorganism to be able to penetrate deeper. So on this picture, this cut section of the skin, you can see the hair follicles. Those pores and the pores of, say, your sweat glands, those allow openings for any type of microorganism to be able to penetrate through the epidermal layer and get deeper into the body. If you had a cut, a scrape, that also allows for the organism to penetrate into the body. Mucous membranes. This is another portal of entry. Your mucous membranes, once again from AMP, remember that's going to line any of your body cavities that have an opening to the environment, the nose, the mouth, etc. This is usually very moist, very warm environment, which is just a wonderful, like, vacation spot for pathogens. It's like, okay, we don't have to fight cold air, we don't have to fight dry air, and maybe be desiccated. No, we can. Moist, warm environment is a beautiful place for pathogens to grow. The gastrointestinal tract, GI tract, this can sometimes be a route of entry. There's a little bit of a harder time with organisms surviving this route of entry because when it hits the stomach is very acidic. It's pH 2. So it must have a way of surviving that acid in the stomach. Very, very common site of entry is the respiratory tract, where you're entering through the nose, through the mouth, even can enter through the eyes. The placenta. Usually the placenta does act as a barrier, protection for the developing fetus. Anything that's in the mother must pass across that placental barrier. So it's usually very effective at providing protection. However, there are some pathogens that can cross that placental barrier and they can infect the developing fetus, usually with devastating results. This table does give an example of some of the pathogens that are known to be able to cross that placental barrier. The parenteral route is not a true port of entry. Excuse me. This is where the pathogen is directly deposited into the tissue beneath the skin or beneath the mucous membrane, maybe by a needle injection if you're not using clean needles. So if the microorganism is able to get in, how does it stay in to cause the infection? One thing is adhesion. This is a way that microorganisms are able to physically attach to your cells. This way they won't be flushed out. If it's able to get in through, say, the respiratory tract, and you inhale, and the microorganism is able to get in and down the bronchial tubes into the lungs, how does it stay attached and not be flushed out or blown out when you exhale? If they attach directly to the cells, that's bad for you, but it's good for the microorganism. It allows it a way of trying to be able to get itself established in you. Usually what happens, as you can see on this diagram, you have the microorganism, you have different factors on the outer, extend out from the outer membrane, outer wall, that are like docking stations to receptors on the host cell. So this is why it'd be very specific. It sees that site, it attaches to it, and now it hangs on. Usually it involves attachment proteins. If the host cell does not have those quote-unquote docking stations, those receptor sites, then it cannot attach. This is one thing that helps play a role as to why an organism that can use a route of entry, say for the respiratory system, but that is not effective with the GI, gastrointestinal tract, is because maybe the cells in the lungs have those receptors or docking stations, but not the ones in the GI tract. And so if it's not there, it can't attach to it and it'll be flushed out. If the organism cannot make these adhesions or these little attachment proteins, it would be what we call avirulent. It's not going to be able to remain there. It won't cause infection and disease. Sometimes bacteria pathogens, instead of attaching to each one attaching to your cell, a few may attach to your cells, and then the bacteria start to attach to each other, and then they form a biofilm, as you can see here. This is dental plaque, maybe a little up close and personal. You don't want to see it close, but the purple are the bacteria, and as you can see, several of them are sticking not directly to the enamel, but to each other. But it is still forming this film of plaque. So infection is when the microorganism invades you. Does it cause disease? Not necessarily. Disease is only when it's going to alter your normal body functions. If it does not alter those normal body functions, then you don't have disease. So you have infection when the microorganism invades you. Do you always have disease? No. So you can have infection without disease. Can you have a disease without infection? No, not if we are talking about those caused by microorganisms. In order to have the disease, you must have the pathogen that's infected the individual and thereby altering those normal body functions. What are some of the manifestations of the disease? We have symptoms, signs, and syndromes. Symptoms are things that are felt by the patient, things like pain, fatigue. I can't measure a level of fatigue in a patient. A patient can say, I'm feeling really tired. A patient can say, I'm feeling pain. Now we can kind of ask them to rate the pain, but we cannot say definitively, yes, your fatigue level is at such 3.2. It's a very subjective measurement. Sign is something that we can measure, but someone else can measure it. You can come and say, you know what? I have a fever. I can get a thermometer and I can measure it and say, you have a fever, yes, of 101.2. I can measure that. A syndrome is when you combine the symptoms and signs together that tend to characterize a particular disorder or disease. Now, this table shows the differences between examples of symptoms and signs. One thing I want to point out is look at some of those symptoms: pain, nausea, headache, chills, fatigue, sore throat. How many different diseases do you know that you can think off the top of your head that have those symptoms? This is one reason why it's very difficult. It's very hard to diagnose purely on symptoms because so many of the symptoms have the exact same, so many diseases have the exact same symptoms on there. This just shows terminology of diseases, things such as, let's see, carcino means cancer. Toxic is going to refer to poison. If it ends with itis, That means it's an inflammation of it. So that's going to help you when you get into a medical terminology course. Excuse. The etiology, this is studying the cause of the disease. Now, some diseases may have various causes, so that can make it a little interesting and trying to narrow down a particular cause for a particular individual. On this table, it does list several of the different categories of diseases. There are a couple that I want to just point out to you. Second from the bottom is idiopathic. That just means there's an unknown cause. We don't know yet what the cause is. The bottom one is healthcare associated, also known as nosocomial infections. These are acquired in a healthcare setting. This is when an individual, say, goes into the hospital with one type of problem, be it maybe they need to go in for surgery, maybe they're sick, and then they develop another infection while in the hospital that they acquired while they were in that healthcare setting. In terms of etiology, how do we study the cause of diseases? This is where it's going to go back to Robert Koch and Koch's postulates. Remember, we've studied this before where he did set up a series of 4 things, Koch's postulates for determining what organism causes what disease. Koch's postulates, just as a reminder here, are shown. Number 1, first step, the suspected agent must be present in every case of the disease. Number 2, you must be able to grow that particular pathogen. You must be able to isolate it and grow it in a pure culture. Number 3, you must take that pure culture, inoculate it into a healthy animal, plant, if you're talking about plant microbiology, and then you must see the same signs and symptoms in that animal. And number 4, you must be able to isolate that same agent from the experimental diseased animal. That is what Koch's postulates state. Now, there are some exceptions to following his postulates. Number 1, some pathogens cannot be cultured in the laboratory. I believe we talked about this before. An example, it would be the bacteria that causes leprosy has never been able to be cultured in pure culture in the laboratory. Some diseases, they're actually caused not by one microorganism, but by a combination of them. So that's another exception that you would have. And certainly the step of where, number 3, where you need to inject or inoculate the organism, suspected organism, into a healthy individual, be it an animal host. There are some diseases that only have a human host that we are aware of. You cannot, under any circumstance, inoculate humans in a trial study where humans are the only host and there is no cure for that disease. You can't do that, obviously. And so we do recognize that there are some exceptions to fulfilling all 4 steps of Koch's postulates. The safety, obviously, if you're using that trying to determine what a causative agent of a disease is, you're trying to help people, so you certainly cannot cause any harm in that process of trying to come up with cures. Virulence factors for these pathogens. When we talk about pathogenicity, this is just referring to the ability of a microorganism to cause disease. It either does or it doesn't. Well, if it can cause disease, okay, then we talk about virulence. How bad is it? Is it a high virulence factor or is it low? If it's low, okay, you may get sick, but not real sick. If it's high virulence, then you're going to really know you're sick. What are some of the factors that will influence how pathogenic an organism is? How virulent is it? Things like adhesion factors. Can it stick to host cells? Biofilms. Does it form extracellular enzymes that help to break down some of our cells? Does it produce toxins? Does it produce factors that help prevent phagocytosis from occurring? This chart just gives a table saying less virulent, meaning it's not going to cause disease, a very low chance of causing disease, versus more virulent, which definitely is going to cause very severe disease. What are some examples of these extracellular enzymes? These are ones that are secreted by the microorganism that are often used to break down components of you. That helps it to invade, it helps it to penetrate further into the body, and also to try to avoid your immune system. Hyaluronidase and collagenase are often produced by some microorganisms. What does this do? Well, the bacteria is able to get through the outermost epithelial layer. If you remember from A&P, epithelial tissue is what is always on the surface of the body. Underneath that is going to be your connective tissue, which often has collagen in it. So if a bacteria infects you, what is it able to do? Hyaluronidase is going to be an enzyme that breaks down some of the connections between cells that allow the bacteria to pass between them now. And then the collagenase is an enzyme that breaks down collagen, which is in the connective tissue just below the epithelial tissue, that allows it to invade even deeper. It's kind of like the bacteria going, oh, you thought you had a layer here? Well, I'm going to just break that down and just penetrate even further. Some organisms have coagulase. This allows the bacteria basically to form clotting. Just like how your blood clots, it forms a clot. But the bacteria exist inside the clot. They're hanging out there. If you have a blood clot, and in the middle of that blood clot is the bacteria, they're on the inside. So they are not visible to your white blood cells that are part of your immune system, whose job is to search and find and destroy anything that is foreign. They don't know the bacteria is in there because they can't see it. So that's very beneficial to the bacteria who can hang out there, who then later produces another enzyme called a kinase that's going to dissolve the clot and now release the bacteria. So it's kind of like a hide and seek game. Sort of like white blood cells, immune cells. Tag, you're it. You got to find me. I'm going to go hide out in the clot. You can't find me. I'm going to wait till you give up and leave. And then I'm going to break down the clot and then continue in my penetration and invasion of your body to cause the disease. Do all microorganisms, do all bacteria, produce all of these enzymes? No, they do not. Some do, some don't. Some may only produce one or two of them. But all those would be considered virulence factors. This picture is just showing, once again, a schematic drawing of the skin and how along the hair follicles, along the pores from your sweat glands, these do provide openings into the body. The sweat and oils that you do produce along the hair follicles and through the sweat glands actually do contain chemicals, from our standpoint, that is good, that help to kill any microorganisms that are trying to enter that way. Some organisms produce toxins. Toxemia refers to when you have the toxins in the bloodstream. Now, these toxins can cause tissue damage. They can cause responses from your immune system that's also going to cause tissue damage. There's two types of toxins. There's exotoxins and endotoxins. The exotoxins, this is where the bacteria are growing and they secrete the exotoxin. Usually this exotoxin is going to, well, depending on the type, it can kill the cell. It can interfere with normal cellular physiological functions, such as with the botulism toxin. It is an exotoxin and it prevents muscle contractions from occurring. The tetanus toxin is secreted, once again, by bacteria. It is an exotoxin. And what happens there, it does not allow a muscle that's contracting to relax. So it interferes with those normal physiological functions. An endotoxin is a toxin that the organism is making. It is released upon death of the microorganism. We mentioned this briefly in the very beginning of the semester when I was talking about the gram-negative bacteria and how in some of the differences between gram-positive and gram-negative with the cell wall, that they have that outer lipopolysaccharide membrane layer. And within that layer is an endotoxin called lipid A. This is released when the bacteria dies. Now, at that point, what happens is this lipid A can trigger certain things in your body, such as the inflammatory response. It can trigger fever. It can trigger shock. It can trigger blood clotting. It can be fatal if you have a high amount of it released all at one time. But it's only released upon death of the gram-negative bacteria. That's one reason why you want to be a little careful. Remember when we talked about antibiotics, etc., and that you do not want to necessarily kill all of the gram-negative bacteria in your body at once, because there would be this sudden increase in lipid A being released, and that's an endotoxin, can lead to shock. This table is showing a comparison of both your exotoxins and endotoxins. Antiphagocytic factors, these are just different factors that prevent your cells from carrying out phagocytosis, or engulfing, basically chewing up and eating for supper the pathogen. One of the biggest things is if the bacteria has a capsule. If it has a capsule around it, we know that this is a virulence factor. It's a benefit to the bacteria, not to you. It's very hard for phagocytes to engulf the capsule. It often has chemicals on the surface that make it very difficult for your essential white blood cells to recognize it as a foreign substance. And then it also can release various chemicals that also interfere with phagocytosis. And that's what these slides here are showing. We divide diseases into different stages as to the progression of it. Usually it's divided into 5 stages: an incubation period, prodromal period, illness, decline, and then convalescence. If you look on this table, you can see the different stages drawn out on a graph. During the incubation period, this is when you've become infected. Oftentimes you are contagious in this period, but you are not showing any signs or symptoms. You're feeling great. You have no idea that you are even contagious at this point. Once again, in terms of current events with coronavirus, this is what we're concerned about, that 14-day period of incubation, where you may have been exposed. You could be contagious, and you may not be showing any symptoms. The prodromal period, this is where you're starting to go, maybe I feel a little achy, I'm not feeling 100%, maybe I have a headache, and you don't really necessarily know yet that maybe this is some serious infectious disease that I have. You may feel just kind of, I feel a little tired. I've been studying a lot for my classes. I'm not getting enough sleep. But you're not showing severe signs or symptoms. Illness is when now you're showing those severe signs and symptoms. You know that you are sick. You may have fever. You may be very tired. You may be very achy. You may be throwing up. You may have diarrhea. It depends on what particular disease it is as to what the symptoms are going to be at this point. But you definitely know that you have it. Why are you now showing more severe signs? Because the number of microorganisms, the number of those pathogens in you has increased to a level that, yes, they are definitely interfering with the normal physiological functions in your body. The decline period is when you've gotten over that hump. You're starting to feel a little bit better. You're not completely well yet, but you're like, okay, I'm going to get through this thing. Kind of that, okay, I'm going to make it. I'm not feeling great, but I'm feeling better than I was 2 days ago. Then convalescent period is where now you show no signs or symptoms. You're on the full road to recovery. During the decline in convalescence period, this is a period that sometimes you're going to find in the medical field that there are problems, especially for people who are used to being very active. Um, they want to get up, oh, I'm feeling better. You want to get moving again. I'm not 100%, but I can get back to work. I can do everything I used to do. And they start to do stuff too soon, and they may have a bit of a relapse. Take the time to recover completely. This table just shows the incubation period, that first stage of various diseases. Staphylococcus food poisoning, less than a day. The influenza virus, about a day. Leprosy, on average, is about 15 years. So obviously it depends on the organism. Coronavirus is 14 days. So you don't have a set time. You have to look to see what the incubation period is. So how do the pathogens get out of you? What are the portals of exit? Somehow they're going to leave. Most portals of exit are going to be the same way they entered, whether it's respiratory, etc. And most of them are going to be leaving in the materials, whether it's fecal material, whether it's sneezing, etc. So for most diseases, what we look at when we study them from a microbiology standpoint is what's the portal of entry, what's the portal of exit. Transmission is going to be from a reservoir, that portal of exit, to another host portal of entry. How does this occur? Contact, vehicle, or vector transmission. Contact can be direct contact, where you have direct body contact between hosts, shaking hands. Indirect can be from touching fomites, a non-living thing. We did this in the lab when we put the yeast on the penny and had you pass the penny around. It can be by droplet transmission, by sneezing, by coughing, etc. With influenza and with coronavirus, it is both of those are upper respiratory diseases, and so the transmission can be by coughing, by sneezing. And this next picture does show why you want to cover your mouth when you sneeze. Have a tissue, sneeze or cough into your elbow so you are not sending all those droplets into the air. That's also why, from your standpoint, if somebody is sneezing near you, you want to be 6 feet away at least, because none of us want that on us. Vehicle transmission, airborne, once again, sneezing, coughing. Waterborne transmission, we're going to see this a lot when we get into specific diseases, especially those that cause diseases of the GI tract, where it's contaminated water, and that's how it is spread. Foodborne is when it's in contaminated food that has not been properly cooked. Maybe it was cooked but then not stored properly. Bodily fluid transmission is when the pathogens carried in like blood, saliva, etc. This just showing different places have different standards on how they store, say, their foods, and that can lead to easy transmission. Vector transmission, this is where you have the pathogen in one host, and then you can have a biological vector organism that then transmits it from one host to another. Oftentimes these are going to be insects. So you have the pathogen in one host, and then say you have a mosquito that's going to bite that host, it gains the pathogen, and then when it goes to another host, it can, and bite the second host, it can transmit the pathogen that way. Sometimes for mechanical vectors, it's not that the insect or the organism bug, whatever, it bites you, it may just, if they have the organism on them and then they touch you, then it can be transmitted. Some of our arthropods that do act as vectors, mosquitoes are a huge one, ticks, fleas, mosquitoes are probably the number one of your arthropod insect vectors. Mechanical vectors, where they just need to touch you, things like houseflies and cockroaches. This shows different examples of modes of transmission, contact, vehicle, and vector, just a summary of the last several slides. Classification of diseases are done many different ways by the body system that they infect, like respiratory, urinary, etc. The effect they have on the population. So here's just different ways of classifying diseases. Are they acute, where the symptoms are going to develop very rapidly, but the disease is going to also run very quickly and then it's over with? Or is it a chronic one, where the symptoms usually develop very slowly, but the disease lasts a long time? So that just shows examples of different types of those infections. Epidemiology is especially within microbiology. Once again, this is the study of where diseases occur, when did they occur, how are they transmitted. It's kind of like you have a new infection coming out. We need to figure out how is it being transmitted. The idea behind it is so we can stop the transmission of it. They will look at the frequency. Epidemiologists will look at incidence versus prevalence. Incidence is the number of new cases in a given area during a given period of time. Prevalence is the number of total cases in a given area during a given period of time. Right now, as I'm sure a lot of you are seeing, that the CDC, with their epidemiologists, and also CDC, as you'll see in a moment, is a national organization. And then each state has its own state epidemiologist. So right now, each state individually is reporting the prevalence of coronavirus within their state. That is, what are the total number of cases at this point in time? On this day, what's the total number of cases that we have, people who are infected with this disease? The incidence would be, say, if you're reporting right now, or you seem to be reporting on a daily basis, the incident would be, okay, today, how many new cases did we have just today? So that gives them an idea as to how the disease is progressing. This is looking at number of cases of AIDS over time in the U.S. in adults, where you can see the number, the prevalence, the blue line is showing the total number, and then the incidence is probably done more on a monthly basis as to the new cases. They will often show this information in graphs, depending on what the information is and what you're trying to show. On the graph on C, you have it broken down by age. So you can see, okay, one thing with diseases, most diseases have a prevalence for certain age groups. So you have maybe one age group where you have a higher number of cases in that age group than other age groups. Some diseases seem to infect males more than females, or vice versa. Some diseases you tend to see peak during certain times of the year. Influenza peaks in the winter months. Excuse me. When polio used to be very high, it tended to peak in the summer. And so depending on what the information they're wanting to gain, they can report it in a variety of different ways that can give them more information to say, ooh, okay, we see a spike of this particular disease in the fall, so we need to be prepared for that. Or we see a spike of this in younger people, so we need to get the word out and let them know. Do you want to report the number of cases by state? Currently, with the coronavirus pandemic, they have been reporting by state. I'm sure a lot of you have seen those graphs where they're reporting where the highest numbers are by state. Epidemiologists are going to use different terms when referring to the numbers or the occurrence of the disease. Endemic is what you tend to have always at any given time. You're going to have a few people who are going to be sick with a particular disease that you're looking at. So you would normally have a background, what you kind of think of a background level, and then you might have little spikes here and there, but nothing major. Sporadic outbreaks is where all of a sudden you have in small locations an outbreak. Epidemic is when you have a lot of numbers within a certain area, say within a certain region, within a certain state. And then a pandemic, which is what we are seeing now, is where you have outbreaks globally, which is one thing that just personally irritates me a little bit when I hear the term global pandemic. It's kind of redundant. A pandemic is globally, where you are having outbreaks not just in one continent, but across several continents. Now, what are the numbers? How many number of cases do you have to have for it to be considered, say, an epidemic? That's going to vary depending on the disease. Years ago in New Mexico, they had an outbreak suddenly of whooping cough. Well, 10 cases within a small area within the state of New Mexico of whooping cough was considered an epidemic, because you don't normally see that number of cases in a small area. That was very unusual. So you can't say, okay, yes, if the number of cases is above 100, now it's an epidemic. It depends on which disease you are talking about. And because of that, like I say, sometimes you might say, oh, okay, well, the number of cases is actually, for an epidemic, may be lower than another disease that's not considered epidemic in cases. And this just shows some of the reporting. There are certain infectious diseases that are usually reported to the CDC. They're required to report these to give us an idea of the numbers. Are we leading towards an epidemic or not? Is it just a sporadic cases? And as you can see, there are several different ones that are listed here. Part of the problem sometimes with reporting is that not everyone who's sick tends to go to the doctor, so therefore they don't know about it and it would not be reported. But if you go to healthcare, if it's identified as any one of these diseases, it must be reported to the CDC. So the epidemiologists, they're going to be monitoring, certainly whenever there is an outbreak. They're going to want to know what was the location, what was the time that the disease, get as much information as they can. The idea behind this is if you can figure out where it started, then stop the cause. If it's food poisoning, then you need to talk to that, say, if it's at a restaurant, you need to talk to that restaurant. You need to investigate what is their food preparation procedures like? What are their food storage procedures like? And if it needs to be shut down, it needs to be shut down, cleaned up, and then educate into the proper storage and production, cooking procedures, etc. You need to look at who all from one initial site, whom all may have been in contact with the first person, and then follow through from there, who may have been exposed, and try to break that transmission as quickly as possible to get a handle on. Oftentimes, these investigations don't happen while the outbreak is occurring. It will occur afterwards. Why? Because when an outbreak is occurring, your main focus is treating the patients and trying to make sure that all of your health facilities can handle the number of patients, they can adequately take care of them. Figure out later where it started from. If it's a new disease, you're going to want to try to figure out what is the causative agent. Go back to Koch's postulates. Nosocomial infections. People are in a healthcare facility, such as a hospital, because they're not feeling well. They already have a weakened defense system. Their immune system is working overtime, so they are more susceptible to contracting secondary type infections. Where can they get that from? They get that infection from possibly another patient, possibly from the environment they're in, the procedures they're getting, possibly from their own microbiota. The normal ones have been compromised, and an opportunistic one, it's like, hey, opportunity knocked at the door and I'm opening it. Here we go. So you take an immunocompromised patient, you put them in an environment that already has microorganisms in it in the hospital setting because you have a lot of sick people there. You have staff, you have patients, you have family members who are moving back and forth between all of this, and all of that can lead to the nosocomial infections. They really try to prevent this from happening, and so there are usually very aggressive control measures to prevent nosocomial infections. One of the best ways is washing hands. In terms of agencies that are dealing with epidemiology and overall public health, each state has its own epidemiologists, as I said earlier, in public health departments. They report information coming from the state. On a national level, there is the Federal Public Health Service. This includes the CDC, the Center for Disease Control, which is in charge of keeping track of all of these outbreaks, monitoring what's happening, what's the causative agent, how to try to prevent it in the future. On a global aspect, it is the World Health Organization who tries to help control, obviously, globally diseases and prevent transmission and monitor things such as numbers, etc. How do you try to prevent disease? Obviously, you try to enforce clean water supply, clean food supply, prevent or reduce number of vectors, reduce number of reservoirs. Try to enforce immunization schedules. That's going to come up in another chapter. The idea is kind of a 90% rule, or what we call herd immunity. If you can have at least 90% of the population protected, how? By vaccinations, or they've already had the disease, that will tend to help protect the remaining 10% who cannot be vaccinated or immunized, or who are susceptible. And that tends to prevent outbreaks. Public health is also going to be trying to deal with treating anyone who has been exposed to a pathogen when you have an outbreak. So find out, who did you eat with? Who were you in association with? We need to go talk to those people and see they potentially are contagious and see how they are doing. If you need to, set up isolation, set up quarantine measures. Any type of disease, just so you know, that's transmitted sexually is very difficult to control because it's hard to control people's, personal lives. Any disease that's transmitted through the air is also very difficult to control. You can't say, you can't cough here, you can't sneeze here. You do the best that you can on educating the public and trying to limit the disease. With current things going on with coronavirus, I did add a few slides. The coronavirus, when you're hearing terms such as flatten the curve, what are they referring to? If you look at this graph, it shows the deep purple one. This is without any type of intervention, meaning without anything like social distancing. You would expect to see, you have your first number of cases, and then you see that dramatic rise in the graph. So where you see the arrow, pandemic outbreak, no intervention. You have this rapid increase in the number of cases. Why? Because people don't know they're sick. Whether they're on the beaches for spring break at Florida, whether they're in big groups, whatever, they're infecting each other. And you get this very high, rapid increase in number of cases. It will peak and then it will start to reduce slowly. Without any intervention, that's what happens. When we say we want to flatten the curve, we would rather see the curve that has the slash marks in it. Delay the increase in number of cases. If you can delay it out, don't have that interaction amongst people, so that prevents more people from getting sick, so you have the number of cases decrease. One reason why this is so important with coronavirus. Coronavirus is a brand new virus, this strain of it in humans. As I said earlier, we know it passed from animals in a live animal market in China, from the animals to humans. This particular strain has never been in humans, so therefore no one has antibodies or protection against it because nobody has seen it before. That means everyone is susceptible to it. Will everyone show disease symptoms? No, not necessarily. Will everyone get extremely sick? No, not necessarily. But everyone will see this as a brand new virus. There is no protection, natural protection that you have. If you can flatten that curve, if you can decrease the amount of exposure between people, fewer people are sick at any given time. As those people who initially were sick and they recover and then they're out in the public, they become part of that percentage of that goal of 90% to help protect remaining people from getting it. If you've already had it, will you get it again? No, you should not, because now you do have antibodies against it. The big thing for flattening the curve is just looking at the number of people at any given time that have the disease. If you have that sharp, sudden increase, and look how high that peak is on that purple one, can our medical facilities handle that number of cases? If everyone is getting sick at the same time, no, the concern is they may not be able to handle it. But if only 50% of the people are sick at a given time, then yes, they could handle that. So that's what they're trying to do. Is obviously we don't want anyone to get sick, but if we can certainly reduce the numbers of how many people have it at a given time, that enables our medical personnel to be able to treat those who are sick. This whole social distancing, this is a link to, I think it's a very effective visual to show the effects of that. So if you wish, you can click on that, and I think it's a very good visual for it. So this is chapter 14, and then we will continue after this with chapter 15. Thank you.